right, we are recording.
Wonderful. Well, welcome everyone. I'm calling to order this meeting of the Assembly Health Policy Committee. It is December 1st at 10 a.m. Let's start with a roll call, please.
Mr. Perez-Verdilla?
Here.
Ms. Solitel? Ms. Allard? Mr. Constant? Mr. Dunbar?
Here.
Thank you. Ms. LaFrance? Ms. Quinn Davidson? And Mr. Rivera. Okay, thank you.
Yep, thanks. And I did get a message from Ms. Quinn Davidson indicating that she was not able to attend, so she's excused. And then as folks come into the meeting, I'll go ahead and announce their arrival. Okay, well, welcome everyone. We've got several items on our agenda today, and wanted to begin with just reminding folks that if you have questions, please put the questions in the chat, and I'll call on you. And we're going to begin with the presentation from the Mental Health Trust. And so with that, I'm going to hand it over to Mike Abbott. Mike.
Thank you, Mr. Chairman. It's great to be with you committee today, and especially pleased to be able to present on the topic of psychiatric crisis care in Anchorage. I've got a PowerPoint with just a few slides that I was hoping to use to sort of guide the conversation. And I'm hoping that one of your able team members will bring that up for the folks that are visualizing this experience to share with us.
Yep. Can we, Chris, are you able to bring up? Yeah, thanks.
Okay, hopefully you can see that.
Great, that looks familiar. Next one, please, Carissa. So the general vision is that we can operate in Anchorage a behavioral health emergency system that is as functional, as supportive, as successful as our physical health emergency system. Right now, if you break your leg or have a heart attack, you're going to call 911, and you can reliably expect that a well-trained and highly competent and readily available team will, well, first that the dispatcher will evaluate your condition, and if necessary, then dispatch paramedics, either from AFD or from one of the very capable volunteers providers in Anchorage. They're going to come to your location in a timely manner. They're going to provide immediate care if necessary on site, and then they're going to support, if necessary, transportation to a facility, likely an emergency room, which is also has access to inpatient care. Well, the same type of services can be provided for behavioral health emergencies. And what we know now from our own experience in Anchorage, as well as experience around the country, is that physical health model is not the right model for reacting to behavioral health emergencies. But we can build a process that has many of the same elements, just delivered differently. So that's our objective, not to replace the existing emergency medical response system, but to augment it. And that's what we believe we can help Anchorage provide in a cost-effective and an efficient manner, one that will improve the community and, more importantly, at least from the Trust's point of view, improve the experience of the patient. Next slide, please. So we believe that this can be implemented in Anchorage in a phased approach. The core elements are a crisis call center, mobile crisis teams, and then stabilization facilities. And it is not necessary that all three of those elements come online at exactly the same time at full functionality. In fact, we are working in other communities in Alaska now and have begun to implement various pieces of this continuum already. And that's what we would propose is possible in Anchorage as well. And we'll talk a little bit more about the individual elements of that, but suffice it to say that even with without all of the key elements being in place from the get-go, we can still significantly improve both patient experience, resource utilization from first responders, and community benefit. And that's what we would hope that Anchorage would be ready for, and that the trust is able to support. So this describes phasing, which would allow Anchorage to initiate mobile crisis team support with some care line and crisis call line support without necessarily having stabilization facilities online right away. The stabilization facilities will likely take the longest to come online for a variety of reasons. And certainly the system will be more effective once they are online, but it is not necessary to wait for those before we get started. And the work that the fire department and the police department are doing now are excellent first steps in this direction. But we believe that there are even better models that will be that are more likely to be successful, potentially less expensive, and better for patient outcomes. So,
Mike, let me interrupt you just for a second and just let everybody know that members Zolotel and LaFrance have now joined during the meeting. Go ahead, Mike.
Thank you, Mr. Chairman. So we can bring this to Anchorage in phases, and it's as I commented during a recent work session, I'm so gratified that the community that I grew up in and have lived in for a pretty long time is not debating about whether or not to provide these many of these functions, but instead is debating how to provide them. And that's an amazing bit of progress that's taken place over the last 5 years. Kudos to the administration, the assembly, first responder departments, and others for bringing this, getting us to where we are today. So the phasing can take place in a couple of different ways. What we believe could work, what we're already have partially implemented in Fairbanks, and what we think Anchorage is ready for as well, would be to start with mobile crisis team work being supported by existing first responder dispatch and the Alaska Care Line, and then build into facility-based stabilization going forward. We've already begun work with both Providence and South Central Foundation to initiate planning work for that facility-based stabilization work. And we're optimistic that one or both of those operations will come online in the near future. Next slide, please. So when we get this system up and running, it would look like what you see on the slide right here, whereby a crisis call center would be established, potentially a statewide operation, one that serves not just Anchorage, but also serves other communities as well. The state already has a crisis care line system in place. It is augmenting that right now as a result of federal legislation. The state will be standing up what's called the 988 system, 988 will be the new national 3-digit code to reach psychiatric crisis support, suicide prevention work, and similar services. We'd like to see that in Anchorage. One of the reasons why it's important that this function ultimately be separated from the existing police and fire dispatch systems is that the call center is actually providing care. It is not simply dispatching resources. As we'll discuss in a few minutes, the vast majority of calls that come into the care line can be resolved without either a mobile crisis team response, first responder activity, or use of a stabilization facility. The vast majority of calls can be resolved by the call center, which will be staffed by a combination of clinicians and peers interacting with folks, again, we would hope across Alaska, and then where necessary, making a more intense response possible and coordinating that. Also, coordinating follow-up and connections going forward for non-emergency services for those folks that have called in. And then that would be supported by mobile crisis teams. So in the event that a personal response was required, then a mobile crisis team would be dispatched. That dispatch function can be done through in the initial phases, can be done by first responder dispatch systems, but we would recommend that over time that dispatching responsibility would transition to the crisis call line. That's what we've seen be successful in other communities that have implemented this. The mobile crisis teams are dispatched. I'll talk a little bit about in a few minutes about what makes them up. And then once the crisis team is on site, they can assess to what extent the concerns can be resolved on the spot, which is the most likely outcome for mobile crisis teams, or if more services, perhaps stabilization, are necessary. It's also important to note that the follow-up work that I described for the call center will continue and will also support patients that are seen by the mobile crisis team as well. And then you get to 23-hour stabilization and potentially, although for the most part not generally necessary, short-term stabilization, and in the rarest of circumstances, actual inpatient care.
Mike, let me pause you just for a second and let everyone know that member Kennedy and Allard have joined the meeting as well. They joined a while ago. And I have a question for you from Ms. Zalatel. Ms. Zalatel?
Thank you, Mr. Chair. Two questions. One is I'd like to hear a little bit more about how Fairbanks is tying into whatever existing emergency services as they've gotten up and running. And then my other question is if we bring this service through the call center utilizing Anchorage and other communities in Alaska, does the call center have capacity, or is there going to need to be an investment in the capacity of the call center by communities so that it can meet the needs statewide? Thanks.
You bet. So Assembly Person Zalatel, let me, if I can defer each of those to a little bit later. I promise I will cover both the Fairbanks experience and the funding and resources necessary for the call center in just a couple of minutes. If that's acceptable, I will ask Carissa to go to the next slide.
Yes, of course. Thank you.
So, crisis call center. We believe that the anticipated demand for services in Alaska would allow for that demand to be met by a single call center. Alaska already has a crisis care line. It is provided by a contractor to the state of Alaska based in Fairbanks. That is the primary suicide prevention resource in state right now. And existing public safety dispatch resources utilize this from time to time. They will refer callers to this to the existing care line when they think there's a good fit. We are working with the state to ultimately expand that care line to first be the 988 provider for the state of Alaska. That will likely take place no later than the summer of 2022. And ultimately to expand the services to the call center functionality that you see described here. This would be a 24/7 operation. It would be staffed with clinicians and peer support specialists and navigators. The goal is not simply to identify a problem and hand it off. The goal is to, whenever possible, resolve the issue on the phone. And the rate of success for this, as we'll talk about in a few minutes, nationally is approximately 90% of calls to the care line or to the crisis call center can be resolved without a more intensive immediate response. That might mean referring people to outpatient resources. It might mean helping family members or coworkers or neighbors understand the resources that are available to them to deal with the situation. It might mean connecting people to a variety of other community-based resources. It might simply be talking through a particularly touchy or difficult situation with the person experiencing it and helping them resolve it in the moment. But it is a highly successful system. Again, dispatching additional resources is one of the functionalities, but it is not the one that is utilized most often. Most often, the issues can be resolved on the phone. Typically, calls can come straight to the 988 number from the community. They can also be referred to the crisis call center from first responder dispatch agencies. So in other jurisdictions that have implemented this, they get a blend of calls. Some of it comes straight from the community, and a lot of it comes from first responder dispatch systems. Either way, the goal is to get resources in the hands of the people that need them. In terms of paying for that, at this point, we are working with the state and potentially with a contractor to try to understand what the cost of this would be to operate this on a statewide basis, this 24/7 service. At this point, we're not recommending community contributions to that expense. Likely, the trust will be involved in funding the planning and the initial startup of it, and then we'll be working with the state to come up with a long-term mechanism for providing that. In many states or regions, 988 services are funded at least in part through surcharges on phones. Similar to 911 surcharges. That is not necessarily what will be the situation in Alaska, but that is certainly one of the options that the state should contemplate going forward. Any questions on the call center before I move on to mobile crisis teams?
Nope, it does not look like there are any questions at this time.
Thanks. Carissa, next slide. And I'm going to pick up the pace here because we've talked a little bit about mobile crisis teams. Our vision of the best model for Anchorage and the model that's being implemented in Fairbanks is not based in either their police or fire response systems. It coordinates with first responders. It is closely aligned with first responders, but it is not run by first responders. And the people that are actually performing the response are not either police or fire employees. In Fairbanks, and I believe what could be possible in Anchorage, these are provided by behavioral health providers. In Fairbanks right now, the typical response is provided by a licensed clinician and a peer specialist. And by peer specialist, I'm speaking of someone with lived experience in typically mental health or addiction or both. And through that experience and training that they're provided, they're able to be a very useful part of a mobile crisis response. So it's typically done in pairs. In Fairbanks, the system is a partnership between Alaska Behavioral Health, which is the largest community mental health provider in Fairbanks, and The Bridge, which is a peer support agency in Fairbanks. So those two agencies team up. The Bridge provides peer specialists, AKBH provides the clinicians, and between them, they respond to calls for this mobile crisis support. In Fairbanks, the system has been up and running for about 6 weeks now. It started at less than 24/7. I believe they are either at or close to 24/7 support now. They're averaging 1 to 3 calls a day currently. They expect that volume to increase as the community becomes aware of the service and as the first responder community becomes more comfortable. Right now, it's being dispatched in Fairbanks by their police and fire dispatch system. Ultimately, I think we hope to work with them to migrate that mobile crisis team dispatch function to a call center. But in the meantime, it's working very well at this limited level. Our understanding is that as of a few days ago, they had about between 60 and 70 calls that the mobile crisis team had responded to during that 6-week period. And that 2/3 of those calls did not require first responder support. So in 2/3 of those calls, first responders, where they might, 2 months ago, those might have been first responder actions, in this case did not require first responders. I also want to mention that it's what we've seen in other jurisdictions and what we would expect here in Anchorage is that oftentimes the initial response to a call will be from a first responder, that the dispatch system won't have enough information to rule out a dangerous situation or something that has an important criminal justice connection. But in many cases, what we've seen in other jurisdictions is that once first responders make an initial assessment, they call in the mobile crisis team, and then they exit the scene. And the mobile crisis team does their work without first responders present. And that appears to be a critically important part of this success.
Mike, I have a
yes.
question for you, Ms. Zolotow.
Thanks. So this is a really great presentation. On peer specialists, do we have a training program, or is there training locally, or is their training being received in Fairbanks that could potentially be imported to Anchorage? I know that that was one of the initial barriers to peer support or peer specialists as we looked at this at its initial stages. Thanks.
The short answer is yes. There is training available. There is certification available. Likely, if Anchorage moves in the direction that we would recommend, that training will have to be scaled up, but that is doable, and the trust will be an active participant in bringing that access to that resource to Anchorage providers.
Thank you. That's fantastic news. I appreciate that.
Next slide, please. And I know I'm getting tight on time, so I'm going to hustle.
Yeah.
The facility-based care is likely to be the least needed, but certainly a critically important part of the ultimate build out of the system here in Anchorage. There are patients that simply need an opportunity to be somewhere else other than the place that may be exacerbating the emergency that they're experiencing, and they do need to go somewhere else. That does not have to be a high intensity operation like API or an emergency room. In fact, and certainly not a jail. In many cases, those environments, again, exacerbate the emergency that the individual may be experiencing. Instead, stabilization facilities that are being established around the country are very low intensity operations. They typically look more like the waiting room of a healthcare provider than they do like the clinical spaces. It's often talked about as a recliner lounge. These are operations where people can go and be supervised and be supported, but for the most part, simply decompress and then work with clinicians and again, peers in this environment to figure out what the next steps necessary for them are. And then potentially again, as I said earlier, in rare circumstances, longer term care, still short term, but more than 23 hours is necessary. And in that situation, then dedicated facilities would need to be established. And these would likely would look a lot more like a hospital than anything that we've talked about before. This would look more like what the psychiatric ward at one of our hospitals would look like. And that, so that's a paradigm that more people are familiar with. Next slide. So this is just the illustration of the experience that we would expect. For every 100 calls that come into a functioning crisis call center, 90% of them are resolved on the phone. 10% might require some form of mobile dispatch. Of those 10, 3 might require transportation to the 23-hour stabilization. And then ultimately, 1 or even fewer of that 100 would have to be admitted to some form of a multi-day support. And this system will take an incredible amount of pressure off of the existing providers. Right now, too many people go to emergency rooms for care that can be provided much less intensively, much less expensively, and much more successfully. And that's where we want to go. Next slide. Mr. Chairman, that concludes my presentation. Want it noted for the record, I'm 2 minutes early.
Good job. Okay, great. I have a couple of questions. Let me just look to see in the chat if there are. Okay, there doesn't appear to be any from members. I have 2 questions. The first one is, can you talk about these are related. This is a behavioral health emergency system, not a comprehensive behavioral health system, right? So this is about the crisis. So I guess one question is there a larger behavioral health system or model that this particular system fits best within, that the city should consider as its sort of comprehensive behavioral health system? So that's one question. And the second is when this work happens at whatever stage, whether it's at the call center, the mobile crisis, the stabilization, what is the process to linking that to additional services, whether that's treatment or other kinds of services, housing, those kinds of things? In the model, what kind of relationship do those things have with other services to transition people into for instance, for those that are in an unstable environment to a more stable environment, for those that are in need of some kind of treatment, how does that work?
Thank you, Mr. Chairman. So I'm going to take your second question first. So when it is functioning at the level that we would ultimately hope for for Anchorage or Alaska, the Crisis Call Center will provide that sort of resource referral system for many elements of the continuum of behavioral health care that is currently available and that we certainly hope we necessarily expand. So whether that's addiction treatment or community mental health resources, outpatient resources, those are all services that the care line the Crisis Call Center can in fact track and be aware of. In some jurisdictions, the crisis care line system is sort of euphemistically referred to as the air traffic control for behavioral health care. So they are a resource for the community generally. Although they're there to support emergencies, they also end up supporting a lot of simply community resource questions. Where can I go to help my family member get care for an addiction or a mental health condition? And the care line or the Crisis Call Center can provide that support. And as well as tracking the outcomes for the folks that are in those in their crises, and following up with them. Did you go to your? Hey, we heard from you last night, and we agreed that today you're going to go to and you're going to call and make an appointment with your mental health provider. Have you made that call yet? Can we help you with that? That's the sort of follow-up that the call center can provide, and we would hope ultimately would provide. And then in terms of how this fits in the overall continuum of behavioral health care, the continuum that exists in Alaska, Anchorage, and then statewide certainly has gaps. And even in areas where we have some providers, in many cases, we don't have enough capacity for the services that we do provide. But we don't have to start from scratch in that area. The community mental health provider system, the inpatient capability, the substance abuse treatment capability, those resources exist, and we're happy to say are generally expanding. And the trust certainly is determined to see that expansion continues, and that it ultimately complements this emergency care that we've been discussing. But we're not recommending a radically different model for the overall continuum for behavioral health care in Anchorage or Alaska.
Great, thanks. And then I have one more question, it looks like, from Ms. Zalato.
Thank you. I just wanted to follow up on Member Perez-Verdia's question. Is it contemplated that this kind of system with the Crisis Call Center could be integrated in with our other community crisis responses like 211 or information responses, so that if someone knows 211, they can get routed to the right resource?
Absolutely. I would expect, I know from in a previous life, working around the 211 system, that they are hungry for resources that they can use to refer people to for a variety of things, including folks that call 211 because they don't know who else to call in the event of a psychiatric crisis. So we would expect 211 to be another source of referrals for a fully functioning call center.
Thanks, Mike, and thank you so much for your presentation. I will just say that I look forward to working with you and other partners. I think the whole committee does in realizing this vision and looking at transitioning our current services into more of this model. So thanks for your time, and I would encourage any member, if they have follow-up questions for you, to reach out to Mike and his team directly.
Thank you, Mr. Chairman.
Yep, thank you. All right, we're going to move on to our second item for the agenda. It is an update from the Health Department. Mr. Gerace, are you on the call?
Yes, sir.
All right, great. We would love to hear an update on all things happening within your area, please. Thanks.
Wow, that is a giant a giant question, but I will do my best.
Yeah.
Great question. So I'll say first, we are continuing a lot of operations and expanding operations around PEH with the warming tank going operational since the last. We are working right now to get medically fragile people into the Sockeye Inn. And so that is in progress. We've moved 9 or 10. We just reacquired that location. Elders and medically fragile people are being moved into that location. We are reestablishing healthcare services through some community partners at the Sullivan. And the big news being that we've started the transition that we had discussed before on the testing locations going to a HRSA model versus a city MOA funded model. Eagle River and the C Street location are operational. The location out near the airport at the Alaska Park is going operational. Muldoon and Change Point are a couple weeks out, but I just wanted to let you know, I've heard discussion that it's going away. Testing is not going away. We're actually adding the site at the Alaska Park. There's still no cost. We are just not funding it through we're having to come back to the assembly for a reappropriation or an additional appropriation to fund testing in town. So I should note those. Vaccine operations are continuing. Fairly low demand for vaccine, both through our outreach programs, and the site at the Diamond Mall continues to operate. But that would be a general overview. I could go into great detail. We all know I like to talk, but I think there's some questions I've had from a lot of assembly members over the last couple of weeks, and that way I could maybe address specific issues from a health policy standpoint, sir.
Yeah, and let me just have you go back quick. Can you explain what you were saying about the Sullivan? What was your update? I think it went a little bit too fast for me.
Oh, no problem, sir. So we haven't had great on-site medical. We've been transporting daily to Anchorage neighborhood, to the Alaska Native Medical Center, and a lot of other providers. We are now going to have the providers actually coming back, which we've been doing before. We're going to have medical providers on site to try to, from vendors being South Central and the Anchorage Neighborhood Health Center, are going to be actually in the shelter for a more hands-on approach to client care. So that'll be a additional step in. We've added the nursing staff that we referred to. We're conducting TB sweeps. We actually found an active TB case during our sweeps, which is a positive thing that we can render medical assistance to someone who desperately needs it. TB being a very, very contagious disease. So with that noted, we are moving forward on providing those ancillary services that we had referred to, being nurses on site to check people with those persistent coughs or a fever, so we're not having a situation where someone fell through the cracks again. And that increase in nurse participation at the congregate and non-congregate sites has resulted in some better health care for the clients currently being sheltered. And the providers coming back on site will be a huge benefit to the clients that we're taking care of at those shelters.
Thank you. And I don't see other questions. I'm going to ask a couple more. If you could also give us a COVID update, sort of the status for Anchorage right now, and also just any information you have about this new variant I'm sure folks are starting to hear about in the news. So any information you can provide on our current situation and the new variant.
Yes, sir. So first, I think everyone's well aware that the two major hospitals have regional and Prov are out of crisis standards of care. which is a positive, not from anything that it causes to happen, because it gives control back to the patients in the care of their situation, whatever they're at the hospital for. So crisis standards of care had resulted in the hospital make some of the decisions. Additionally, due to the reproductive rate having dropped below 1.0 for the last 14 days, we're at a 0.81 today. We've been hovering in the 0.84, 0.82, 0.81 region, which anything below 1 we felt was going to be an improvement. As our acting mayor had noted, that's a kind of milestone we try to reach for. So I would say that it's improving. I don't want to be misconstrued in saying we're out of the woods. Our situation appears to be less dire than it was 2 months ago, a month ago. With that, we still need to be vigilant. You know, all the things that apply to reducing exposures applies to the new variant, and the flu has been going around. We've had some norovirus going around. There's a lot of other things. TB is an example. All the same preventative measures that apply for COVID help with any airborne, air transmitted disease. And then hand washing for the direct contacts is a secondary benefit. So COVID is, cases are trending down. I'm not saying things are better. Cases are trending down. Overall, there was only 300 and plus cases as opposed to 12 or 1,500. So statewide, you know, the situation is not as dire as it was. We still need to be guarded. I mean, you know, we are not out of the woods yet. And that loops me to the new variant. You know, very early discussions on the new variant. I've read many articles on this, and some say it's going to be worse. Some say it's more infectious but less severe. It is literally a 7 or 10 day discussion, and the countries that have it don't have the same kind of great reporting system that some of the other countries that don't have it yet. So we're looking for some data out of some places that are fairly remote. And as we get that and get some information, I think we can make some more informed decisions. As you saw, the president has banned travel from 7 or 8 you know, African continent countries. I see a travel ban in many other places. I'm just noting that while it doesn't affect Alaska, I do note that, you know, they are doing everything they can at a federal level to try to abate it coming to the continental United States and then to us. You know, as everyone's aware in this room, we're always kind of behind the curve. Comes later to Alaska and it stays later, and that applies to cold and flu, everything. We just have a different cycle in Alaska than the lower 48. So we're being guarded. You know, that's why we haven't discontinued testing. We've actually expanded. We have 25,000 home test kits that we're distributing. We've been out since doing that since the middle of November. We've been distributing home test kits, particularly to some of the more heavily affected, like congregate, ALFs, and some of those kind of homes. So the health department has not been sitting around. We've acquired 25,000 test kits and have been distributing them in our regular rounds of our testing and vaccinations at ALFs and other long-term care facilities, our shelters, other shelters. We're a partner with a lot of community partners, and we've been empowering them through having additional test kits for the times that we're not available to be there immediately.
Great. And then just my second question was around staffing. There's been some news reports around this, but I just wanted to kind of get any update you have on your staffing. I know that we're in the middle of a budget process and there's some uncertainty related to that. But are there any staffing updates that you can provide for us in terms of there's been some turnover and change. Where are you at, and where are you at now?
So I guess in general, we continue to recruit and hire. We have not had a hiring freeze here at the health department. So we have onboarded people in the last, 30 days. From a staffing standpoint, the last division manager job, which would have been Christy Lawton's job. I'm gonna have to turn off my camera. I apologize. I'm getting feedback. Christy Lawton's job is with the executive team on the 8th floor. As it is an executive appointment, we don't actually control that. But the sub-division manager jobs, we've been continuing to recruit and hire. We've hired some public health nurses, PHNs. We've hired a homeless resource coordinator in the last 30 days. We have 2 of those positions. We have filled one of them, and we have a candidate for the second position. So I have heard that question. The turnover, I think the major turnover you may be referring to was the reproductive health doctor departed. She was 4 hours every 2 weeks. We've had a onboarding of 5 positions that were funded by the CDC. So while we haven't added any city ABA or non-rep employees, we have had some grant funded positions that have arrived, and we've been using those positions to prop up the operations that we haven't been able to hire for. Truthfully, public health nurses, we've had a very difficult time. I'm going to be truthful, recruiting them because there's so much demand for nurses right now. The city's pay is not commensurate with what the current market will hold. So we've had a very difficult time. We have 5 to 6 public health nurse jobs sitting open, and we just can't recruit for them at this current time.
Okay. And then at the last meeting, you had mentioned that you're in the process of trying to hire an epidemiologist. What is the status of that?
Excellent question. So the in-house epidemiologist job is executive appointment. A finalist has been identified and is sitting in the mayor's office for hire. We did hire through the CDC, funded an epidemiologist around some COVID-19 and some communicable disease tracking. That person has been made an offer from the CDC and will begin December 15th supporting operations here at the health department. So we actually will have 2 epidemiologists. One is a traditional in-house, PCN employee, and the other will be a contract paid for by the CDC to support some of the one-off work around COVID-19 and that data, and a lot of the stuff that you would be in the health metrics report will be, he's an MD, PhD, kind of a great hire. We didn't just get a public health, MPH person. We actually got an MD, PhD with a long background doing research in communicable disease. And it's really a great, we couldn't have, out of all the candidates they could have found for us, we probably couldn't have asked for a better candidate than they found us. And I'm really excited to have him joining the team.
Great. And it looks like I have a question from member LaFrance.
Thank you, Mr. Chair, and thank you, Mr. Gerace. 2 questions. I just wanted to go back to what you were saying about staffing and just ask if you knew offhand or so what the attrition rate for public health nurses in your department is. I know that the FEMA nurses are getting paid high, pretty substantial wages, and that I, anecdotally have heard that's drawing some nurses from other organizations away, to apply for those jobs. And then I guess second, we received an email concerning a supply drive at the Sullivan for individuals staying at the Sullivan Arena, and supposedly the supply drive is sponsored by Muni employees, and it was reported there was some difficulty in bringing those supplies, those donations to the Sullivan. So I just wanted to ask if you had any details about that. Thanks.
Yes, ma'am. To your first question, we have not lost any nurses to outside agencies in the last 6 months that I've been told of. We have had a problem recruiting to fill the positions due to basically the effective hourly rate, even with the step increase given to them to the top step. We don't meet current market, but luckily our nurses have seen the value in staying with a long-term employer, recognizing that this is kind of temp work. And I think that's what's prevented us from recruiting more, but a lot of them see the investment in the long term of being with the MOA. Our turnover rate at the health department for the last 4 years has hovered in the 16% range. We detected that when I first came on board. We did a 2-year study backwards. It detected the same problem. So we went back 4 years in partnership with HR and labor relations, and we've had an historic turnover rate in the 16% range. And a lot of that does exactly, even outside of COVID, the requirements for a lot of our jobs are fairly substantial. For instance, take our public health nurses. It's not just a nursing license. They have to be a BSN. And so they have to have a bachelor's in nursing, which eliminates all of the associates in nursing and the nursing school nurses because they don't have that BSN. So for instance, that would require then a decent increase in level of licensure. So it doesn't change their licensure, they're all RNs, but the underlying degree causes those folks can get a much higher wage in a hospital setting, a BSN versus just a traditional RN. So that has created some of the struggle. But to your second question, there's been we just got that email yesterday and we've been investigating that. The municipal manager's office, due to it being a municipal program, has taken the lead on that. And we have a sit down today with the vendor to find out what occurred around the drop off of the supplies. But I don't really have any information. It's so new to coming to the health department. We just got into the business of it yesterday. And then again, this morning, we had a 7 a.m. with the municipal manager's office, and they're running down some of the, other information you asked about it being a municipal program. I can't speak to that this exact second. It's so new that I haven't gotten the full details yet. I don't want to give you bad information.
Understood. Thank you, Mr. Gerace. I appreciate also that attrition-wise, you have not lost any nurses in the last 6 months, so that's good to hear. Thank you, Mr. Chair.
Thank you. And I don't see any additional questions in the queue at this point. Mr. Gerace, do you have anything else you'd like to share before we close your report?
No, sir. And I'm available for questions, particularly if you have stuff you'd like me to bring to this meeting, please feel free just to get it to me and I'll run it down. I'm all about research and bringing back factual answers to you folks. And I try to deliver factual answers when you ask for stuff. So please just get it to me and I'll run it to ground as fast as I can.
Thank you. And we are still contracting to get the weekly COVID updates. Is that's still coming out of your office, correct?
Yes, sir.
Okay.
The health metrics report is still a weekly meet with Agnew Beck. And, our community partners, there's a couple people that help us with data, DHSS and others. A lot of that data is passed through from the state, and then we refine it for that health metrics report because it's not always MOA centric or specific data. So correct. It is funded through the end of the year. We are drawing up AOs to refund programs into 22 as we speak. So we are looking at that, but great. Affirmative. It is funded through the end of the year. Yes, sir.
I'd like to figure out a way for us to have that being forwarded to Carissa and that being put on the health policy website. So if we could just have that be sort of an automatic push when those come out, to have Carissa put that up on our site. That way we don't have to remind anyone. If we could just start doing that, that would be really helpful.
Noted, sir.
Okay, noted. Thanks. Great. All right. And so the last item for our agenda is I had a conversation with member Zolotel in terms of an annual agenda for this committee. We will continue to have updates from the health department at every meeting, but I really want to make sure that we are identifying some of the most important priorities and working on those over the next year. So I wanted to create a little bit of space before we go to public comment to see if there are members of this committee that have health policy issues or items that they want to make sure that this committee addresses over the next year. It's my intention to work with Ms. Zolotel to develop an annual agenda. So we're looking forward and looking at what our priorities are over the next year. So I just want to create a little bit of space. If there are members who brought forward priorities they'd like to make sure that we're addressing over the next year. Feel free to unmute and speak freely.
Hi, Mr. Chair. This is Ms. Zolotel. While we have prior co-chair Suzanne LaFrance on the line, I would like to have her tell us a little bit about the prior work, and I think we need to maybe update that work on the substance misuse community assessment, if she doesn't mind, so that we can get just a little bit more sense into getting some direction on where we might want to go with that.
I'd be happy to touch on that, Mr. Chair.
Sure, go ahead, please.
Okay, so thinking back here to a few years ago when the Health Policy Committee was just started, there were a number of, I think there was a work session in the Public Safety Committee meeting or two about opioids. And so substance misuse and behavioral health became a focus, particularly substance misuse. and the health department was involved with the community, and Ms. Zalatel just said the name. What was it again? The
Community assessment.
The community assessment. I can't remember the full name, and I don't have my copy in front of me. And so we spent a few meetings going through the results, talking about the methodology, looking at some of the factors, especially impacting Anchorage. And then we had started also to move into discussions of behavioral health and looking at treatment options. We had some meetings focused on that, resulting from that assessment. And then also the Tobacco 21 ordinance that was passed by the Assembly was heavily worked, kind of as part of that assessment. It was a piece of it, but it was worked in the committee. And then at a certain point, COVID hit, and it took a different approach. Sorry, Meg, I didn't really provide a whole lot of detail, except that we spent quite a bit of time looking at the assessment and talking about it in the committee. And making a couple of the changes, like the language. It's coming back a little bit to me now. Changing some of the language in the code to be more aligned with the recommendations in the assessment.
Great. No, thank you. That's really helpful. It's my interest to explore that work, how we can build on that work, and how that work then marries with the alcohol tax funding and our response as a community to substance misuse, as well as the investment we have with ML&P funds. So thank you very much, Ms. LaFrance. That's very, very helpful.
That's great. And Mr. Franz, I'm sure we can track it down, but I'd love to get a copy of that assessment wherever it exists. So.
Yes, absolutely. I can get that to you. And part of it was the assessment had recommendations and concerning policy changes for the muni, and then a code change. So I will find that as well.
Thanks. And I don't see anybody else in the queue at this point. I did want to mention that SAMHSA does have a document that I found really, really good. It's called Mayor's Resource Guide on Behavioral Health Issues. And I was thinking about that comment that Mike Abbott made around the gaps in our behavioral health system in Anchorage. And so I'm with that assessment that you have, and any other information we can find, it would be important for me to identify what are some of the priorities that we need to be addressing as it relates specifically to behavioral health as well. So I don't see, is there any other comments before we move on? Yes.
Yes, Mr. Chair. One more idea I wanted to put out there is that I think we should look at how the municipality can support workforce development, particularly in areas of substance misuse, behavioral health, and public health. I think coming out of COVID-19 and this pandemic, we really need to look at the resiliency of our workforce in these areas. And while this is the Health Policy Committee, some of the policy recommendations I could see coming out might be a little bit broader, but it may be those things necessary to entice and incentivize work in these fields. Thank you.
Thanks. All right, we only have a couple of minutes left in this meeting. I did want to create a little bit of space for audience participation. Is there anybody who is on who would like to speak from the audience, from the community? If so, unmute yourself. Does not appear we have any. All right. Well, with that, just want to close by saying that it's my intention to come back at the next meeting with some specific ideas about this agenda that's going to sort of take us over the next year. I'll work with members of Zalatel to create that. And I want to wish all of you a wonderful day. This meeting is adjourned. Thank you. Bye-bye.